Welcome to the Explainer. Today, we're going to break down a really crucial clinical challenge. How do we prevent dangerous blood clots in kids who are fighting cancer? We're diving into the key points from a presentation by medical residents Diego García Mañez and Patricia Luis Herrera. Okay, let's jump right in. The first thing you've got to grasp is that this isn't some rare, one-off event. For these young patients, thrombosis, or blood clotting, is a major, common threat that puts another huge hurdle in front of them during an already difficult treatment journey. So here's how we're going to tackle this. First, we'll unpack that hidden risk. Then we'll get into what causes it and the defenses we have. After that, we'll see how those defenses are actually put into practice, how we measure risk for each individual patient, and finally, we are going to zero in on the one big challenge that makes this a uniquely pediatric problem. All right, let's start with the why. Why is this one complication something that demands so much of our attention in an already packed clinical setting? Well, the risk here isn't coming from just one place. It's really a triple threat. You've got factors related to the patient's own body, factors related to the specific type of cancer they have, and get this, factors related to the very treatments we use to save their lives, like certain chemotherapies and central lines. And look, this isn't just some abstract theoretical concern. It's so serious that it's actively managed in major treatment plans. For instance, this big protocol for acute lymphoblastic leukemia has thrombosis prevention built right into its DNA. That just goes to show you how tangled up this problem is with frontline cancer care. So, we've identified the risks. What's in our clinical toolkit? What are we actually fighting them with? Our defenses, well, they're basically twofold. On one side, you have pharmacological strategies, medications. And on the other, you have non-drug approaches, things like physical methods and other kinds of supportive care that can help bring that risk down. And this gives us a little peek inside that medication toolbox. You've got the established players like low molecular weight heparin, but we're also seeing these newer tools like direct oral anticoagulants, or DOACs, and they're really starting to change the whole landscape of treatment and prevention. So, okay, having the tools is one thing, but the real art is knowing exactly how and when to use them effectively out there in the real world with real patients. In practice, it's a pretty logical sequence. You start by figuring out the individual child's baseline risk. Then, you add in the specific risks that come with their treatment plan. From there, you pick the right prevention strategy, and then, and this is so important, you monitor them like a hawk to make sure it's working and not causing other issues. And that leads us straight to, honestly, the most critical question in this whole process. How do we actually know which kid is at the highest risk to begin with? This is it. This is the question every clinician has to ask. These are powerful drugs with their own side effects, so you can't just give them to every child. The whole game is about accurately figuring out the risk so you only treat the kids who truly, truly need it. To make that call, clinicians turn to these things called scoring systems. But as you can see from this table, while we've got a few options, like the well-known Khorana score, you start to see a really big pattern emerge. Most of these tools, they were designed for and tested on adults. And that right there, that brings us to the absolute core message of this whole explainer, the fundamental problem that we have to solve. So here it is, the bottom line. We are often using tools on children that were never designed for them. A child's body isn't just a mini adult's, and the cancers they get are often different too. This is a huge gap in modern pediatric care. So what this all means is that we need a fundamental shift in how we do things. We can't just keep trying to make adult models fit and hope for the best. We need to build new ones from the ground up, using pediatric data. Now, that's a massive challenge because getting that kind of high-quality data in kids is incredibly hard. But it's absolutely essential if we want to make the safest and most effective decisions for them. So we end up right back where we started, but with a much, much sharper focus. The central, unresolved question for the field isn't if we should prevent these clots, we know we should. It's how. How can we reliably and accurately predict the risk in our youngest, most vulnerable patients? That is the challenge that lies ahead.